once we get folks in.
Broadcasting.
Thanks everybody for joining. We'll get started in just a few minutes as folks log on. I'm going to wait one more minute and then we'll get started. Okay, I'm gonna get us started. Thank you everybody for joining us today. I'm Chrissy Giuliano. I'm the Executive Director of the Big Cities Health Coalition. BCHC is a forum for the leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. Gabby, can you go to the next slide? You can see as we change the slide there, our member jurisdictions. We so appreciate everybody for attending today. We've had a series of these discussions and they've been both well attended and really shared some excellent information. One of our speakers is having a little bit of technical difficulty with his camera, but he's here. So I'm gonna kick off our speaker. Let's go to the next slide. I'm gonna introduce our speakers. I'm sorry, actually I'm going to do housekeeping first. This session is being recorded. All of your lines are muted except for the speakers. You can use your raise your hand feature in Zoom or chat Gabrielle Nichols if you have a technical difficulty. And then you can also put questions in the chat box, which we'll address about halfway through the session. With that, let's go to the slide. Thank you. So today we have two of our Big Cities Health Coalition members from Texas who are in neighboring jurisdictions. So Dr. Phil Huang has been the director.
Uh-oh.
Chrissy, we lost you.
Okay, I wasn't sure if that was me or her.
Sorry about the technical difficulties. Looks like she's coming back on.
Sorry about that. My internet died at just that moment. Can you hear me?
Yes.
Okay, sorry about that. That hasn't happened yet. That's a new occurrence. So I was talking about all of Phil's wonderful education. So happy to have you here, Phil. Thank you so much.
Thanks.
We also have Vinny Taneja, who has served as the health director for Tarrant County Public Health since September of 2014. Prior to Tarrant County, he served as the deputy health officer for a large urban county health department in Michigan. He received a medical degree from Manipal, though maybe I'm saying that wrong, Vinny, Academy in India, and a Master's of Public Health from Eastern Kentucky University. Vinny also graduated as a fellow from the Mid-America Regional Public Health Leadership Institution at University of Illinois in Chicago. So again, thank you both for being here today. I really appreciate it. I think we'll take the slides down and chat. Vinny, I don't know how your technology is, but we're happy to hear your voice, even if we can't see you.
Well, thank you for having me on, and I'm still working. IT made some change, and now there's an additional, safe link, something on the top of the link, and I can't get rid of it. So that's what the issue is.
Okay. All right, that's good. Well, we're, like I said, happy to hear your voice. All right, so before we sort of dive into the current situation on the ground in your areas, I want to back up a little bit to think about the early days of the outbreak. You know, in February, March, even April, you all in Texas had fewer cases. The epicenter of the pandemic was elsewhere in the country. So what were you doing in those days that helped you prepare for what you're seeing now? What, if anything, did you learn from observing what was going on in other cities and states across the country?
Phil, did you want to go first?
Either way. You want to start? Okay, well, I'll start. We were glad, and being in Dallas, we were glad we weren't the first in the country. Like Ebola, I think Dallas was ground zero. That was before I was here, but certainly many here had that experience. So it was definitely good not to be the first on that. And so we were absolutely seeing what was going on with our colleagues in the other communities, Washington, California, and a lot of it was, getting, reporting the status in our own community, really preparing our community for what was to come ahead. Our county judge is really the public official that's in charge of emergency response, so worked closely with him. He developed a real comprehensive team that's to be prepared for our entire response from multiple channels, from our emergency operations and everyone, and really, starting that communication with our community, reporting the numbers that we were, seeing across the country as well as locally, and convening the communication channels, working with different, the business sector, schools, had a call with the school superintendents, trying to share and prepare, for what was to come. It's interesting to think back when we had the conversation with the schools superintendent saying, really need to take this seriously about what it would be like if next week we said we need to start doing a distance learning. And it still didn't seem totally real, but as it played out, obviously, but that was what we were trying to prepare for. One thing I want to mention, again, we were able to learn from others and seeing what happened with the nursing homes and some of the other parts of the country, but really benefited from the networks and communication that we have through like Big Cities Health Coalition, because I know Tomas Aragon in San Francisco, I think they were first to do the shelter-in-place order, and it was through Big Cities Health Coalition that got that draft of what they were issuing for that shelter-in-place order, and we absolutely took that as a template to start and write our own with our judge. And Dallas County, we were actually the first county in Texas to issue a shelter-in-place order, and that communication and networking and seeing what was going on and learning from the best practices from other places was very helpful for us. But again, it was really laying the foundation, preparing people, saying, we're trying to containment now, but be prepared for mitigation as things go forward, and also developing our systems for all of these, what we're dealing with now. Let me leave it at that.
Right.
Well, that was a good summary, Phil. So Tarrant County was doing, stuff similarly. If you all are not familiar, we're like the twin metros, right? I mean, you know, Dallas and Fort Worth are together. What separates us is the DFW airport that lies in between. It's a pretty large landmass airport, city of its own, really, but that's really what separates us. Otherwise, we're all in one community, all in one metroplex. So whatever impacts Dallas usually impacts us. So we're right there with him on a lot of this. Similar preparation going on. Of course, when things were moving overseas, we were watching. You know, when the airports that were funneling airports went from F5 to F11, Tarrant County actually was kind of on the hook more than Dallas because the terminals opened up in Tarrant County. The going joke is keep the plane on tarmac in Dallas County because that's where they land, but passengers deplane into Tarrant County, so that's all fun. So we had to work with the CDC quarantine station folks quite a bit to, you know, get prepared at that point. But things quickly escalated, right? I mean, y'all remember that, you know, we started to have local issues when Dallas identified their first localized transmission. They went ahead with their control order to close down schools and start, you know, tightening things up. And pretty much the next morning, we did the same. We had at that point, I believe, 8 travel-related cases, no local transmission identified, but because Dallas and us are not any different, we went ahead and, you know, got an early start. And I think we're still reaping the benefits of all of that, even though we've had a lot of cases. I mean, we're about 26,000 now, but the trajectory forever was lowered and the curve was bent. So that's one of the lessons learned early on, that starting early helps you a lot. What we learned from 1918, I think it got lost a little bit with our, you know, leaders, is that you got to stay late, right? Start the party early, stay late. That part I think got missed, you know. So we did see an upsurge in cases as, you know, Texas reopened, but we're still reaping the benefits. I mean, you know, at least in Tarrant County, I can tell you the trajectory was flat, visibly flat for quite a while on our epi curves. And even with the surge, it's not been an exponential surge like we've seen in other places. It's been fairly, I mean, it's, when you're in it, you feel it, but it's fairly, you know, controlled.
So I want you both to know that last night I did Google the metro areas of Texas, and you guys as a metro area are the largest metro area in the state, larger even than Houston by about 500,000 people, according to the internet. So glad to have this, right? This big city perspective. So
Fortune 500 companies too.
Oh, wow, good to know. That didn't pop up in my population Google. So Vinny, you moved us a little bit to the present. You know, Texas has seen some rapidly rising caseloads, you know, some additional deaths and things like that. So Phil, why don't we go back to you? Tell us a little bit about what's going on, you know, currently, and sort of what's the biggest challenge you're seeing these days, you know, as you respond to the outbreaks now.
Sure. Well,
Yeah,
so you know, so we actually have about 48,000 cases now that have been reported in Dallas. We had a string there of 18 days in a row with 1,000 or more cases. We're now down today, like we're reporting 789. So we've got dropped below 1,000. As Vinny mentioned, we really were successful at the beginning by responding very early, again, benefiting from seeing what others were doing. And we sheltered in place very early, and we flattened the curve. And in some ways, we were a victim of our own success. What's wild, you know, there was a lot of politics with this. You know, at the state level, when it was time to shut things down or went to shelter in place, they said, oh, that needs to be local control, locals do it. So we were doing those orders and issuing that. Then, you know, when we had the success, but we never saw the 14 days of declines that everyone said and we said need to happen before you open up. And one thing I do want to give a plug for, we early on we had an expert group of infectious disease docs, public health, epidemiology, that created some documents. One of them was this guidance document for our community with a color-coded risk level thing, and encourage you to look at that, because it's still actually served us well throughout this. But, you know, red, orange, yellow, green, and we've still been in red because we never saw that 14 days of declines. But what happened then is the governor, when it's time to open, said, okay, I'm going to open, and here's this Open Texas plan, and locals then can't do anything to go against his plan. So when it came time to open, which at the time seemed like the politically popular thing, oh yeah, everyone wants to get back to normal and open it up, and locals had no control to do anything more strict or put restrictions if we started seeing any problems locally. Well, then, you know, we started seeing these problems in record numbers. You know, I said 18 days of 1,000 or more people, new cases, and our hospitals have been at highest levels we've seen, ICU admissions, all of that. And then he said, well, you know, and we're saying, sending our judge is sending letters saying we really need to do more, restrictions. We need to have masking. Then this was comical almost. It'd be comical if it weren't so tragic. You know, he said, I think it was San Antonio or Bexar County put out an order. We'll require businesses to require masks. And then he said, oh, you found my secret path. I said you couldn't penalize people for masks, but you could penalize businesses. So it was this riddle for all of us to figure out, is what he's saying, that, oh, that's the way then we could restrict and require some masks. Now, as things have gotten a little further, there have been a mask order that's come from the state. But, you know, I think that right now we are starting to see some benefits of it. Our modelers are seeing impact. We're not, you know, absolutely no one can let up, and we're trying to make sure that that message stays out there. But we're starting to really see some benefits, we think, from the universal masking. It hasn't, the lag time hasn't hit our hospitals or ICUs yet, but we're seeing decreased numbers and some positive things.
So guys, this is Vinny. Hopefully now the video shows up. I had to re-register. So I echo Phil. You know, the way things were going, we were pretty flat. I mean, if you have got a chance to go look at our dashboard for Tarrant County, it's coronavirus.tarrantcounty.com. It's very similar to what Dallas's picture looks like. Our numbers are just a little bit lower. And I keep claiming that that's because we got an earlier start. He had local transmission, we didn't. That's the real difference. You know, but it was pretty flat. I mean, we held it throughout March and almost most of April. And we were building the case about how to reopen, and we're looking at the White House plan for reopening America. You know, it seemed like that was at least a logical start on how to go about looking at reopening. And so we were looking at all those gating criteria, doing weekly updates in our county commissioner's court, sort of to, you know, make sure that they're not trying to go too fast and you know, build a base that there will be a time when things are declining and we'll reopen. And I remember distinctly, and that data shows up on our dashboard, April 17th, the governor came out and he said, in 10 days, we will reopen Texas and I will lay out a plan. Well, people did not wait. That afternoon, I was going home, and there were people out on the streets. Cars were there, heavy traffic. I'm like, we're not reopened yet, but okay. And the spike showed up that day. I mean, you know, it shows up on the data a few days later, but April 17th has a spike on our chart. That was the first visible spike. Before that, it was pretty flat, just kind of, you know, simmering. And so from that point on, it just kind of took off. And for Tarrant County, it peaked at end of April. And then, since we had this impact of flattening the curve, that was a short-lived peak, and all throughout May, we were declining for almost, you know, all the way and even into early June. And what happened was, during that time frame, Governor had a phased reopening plan. There was phase 1, phase 2, phase 3, and phase 3 happened around Memorial Day. All kinds of things happened around that time. We had protests in Fort Worth and in Dallas, Memorial Day get-togethers, all kinds of things. Just, you know, things just got out of hand. So that's where the surge started, and then things just kind of turned around, and we started to have these huge, you know, numbers just being added to our total. And that went on even till now. I think just now we're starting to see a little bit of a plateau and a downturn in our data, but that has continued on all this while. Now, again, I think the trajectory has been permanently bent because we got such a good start. But what got missed, and again, Phil's right, local control went away. The governor has chided us several times if other health departments across Texas or other counties across Texas have tried to do anything, that his governor's order, is the supreme order and no local order shall apply, and it gets promptly overruled. So that has been a challenge. Case in point, Phil is a local health authority as well as the health director, and I have a medical, director who's the health authority. We did a school delay order that got overruled yesterday, opinion from the Attorney General of Texas. Now schools have to decide when they're going to reopen, and there's going to be pressure upon them to reopen soon. We were trying to delay it. So things like that have kind of gotten in the way, but, there has been a huge surge, no denying it, but it's because the phased approach was supposed to, at every step evaluate and roll back. And I think they've been very hesitant to roll back. They've done some stuff, allowed businesses to put masking orders on, allowed local health departments to, through their counties, put masking orders on for businesses, close back down bars and some other, things, reduce capacity on restaurant, indoor dining. But I don't think that's been done enough. It really needs to roll back to either phase 2 or some other things have to happen to break this curve. The masking is having an impact. We can certainly see it, but it's quite a slow impact. And case tallies, as Phil was saying, he had like 18, 19 days of straight 1,000 cases a day. That's a lot to handle for any local health department. We're not, huge like New York and LA. We're pretty mildly staffed. My staff before the pandemic was 350 total. So for a county of 2 million people, that's not a whole lot of people. So that's where we are. It's a upward trajectory since Memorial Day. But yeah, we're seeing some breaks in the last couple of weeks. There's been a plateau and a downturn, quite honestly related to the masking. We see that out in the public. Before the masking order went into effect, there was hardly anybody wanting to wear a mask if you go to a store. I was probably the only one and maybe one other person. And now it's flipped. Everybody's wearing a mask and maybe a couple of people show up without it. So that's helped quite a bit.
Great, thank you. So there's a couple of questions about contact tracing. So, Vinny, you touched on sort of when you have all these cases that y'all are seeing and, the size of health departments, really no matter how large many of your departments are, it's still going to be a challenge. So how have you both managed to sort of keep up with that caseload, do the contact tracing work that you would like to be doing? Have you been able to get to a critical mass? I know some other folks in the Big Cities Health Coalition have said there's just been so much focus on contact tracing. It's killing us. There are all these other, that was a terrible choice of words, but it's exhausting the staff. There's so many other things that we can and should be doing as well. So what does that look like for both of you in the work in your departments?
Well, we certainly tried to get a message out again early that, initially when the numbers are low, we'll be trying to containment. And then after the numbers get too big, it's mitigation, and we don't, interview everyone who has flu and try to find out their contacts. As when we got to close to 200, submitted a proposal to our commissioner's court based on 200 cases a day, that then we included a budget for getting 260 new staff for contact tracing. We've been looking at our systems. In Texas, it's a really primitive system. It's gotten even, New York Times article about how much, and probably others, but, faxes, it is paper-based systems for some of these things. It's on the fly, things that have been worked for, maybe sexually transmitted infections or foodborne outbreaks are not the same when we're dealing with 1,000 cases a day. So one thing that we did, and we're continuing to look at the technology, interested in hearing what others are doing. Parkland Hospital is just this gem of a resource in our community. We've also been working with this group, Parkland Center for Clinical Innovation, on a lot of analytics, GIS stuff. But they offered for us to tap into their some of their IT resources. Their Qualtrics is a resource. So they set up for us a system where every day, at least, we send them a flat file of all of our new cases. And so can now say everyone that has either a cell phone number or an email, so they've set it into the Qualtrics system. Every one of the new cases within 24 hours is sent a text message or an email with a link to a brief survey that they can fill out that survey. And, it has some basic questions, some symptom questions, and then also, defining close contact and asking them to name and give contact information for any close contacts. Then those close contacts are immediately sent a text that with a PDF that informs them they've been identified as a contact with someone who's tested positive, with a link to CDC resources, advises them to quarantine for 14 days. It has some links to other social services resources. So at least we have a system that we can say, within 24 hours, every new case is that we've got the information on, can send that, is contacted, informed, and they are given the opportunity to provide contact information, and all of those contacts are messaged immediately. So given the volume of cases, that's something that we can do in an automated way. We've actually been getting over 40% completion on that survey, which is, and a lot more that have opened it, haven't completed it, but and thousands of contacts have been identified. So as a start, we are looking at then up on the upfront end, other ways of addressing the processes, the database, the input, dealing with all the lab reporting and how we can automate some of that. But that's something that we're hoping to then be able to have in place more when the numbers do get down to more of a manageable level. But yeah, contact tracing has been this, no one ever knew about contact tracing before. And then now everyone's an expert on it and, on this, asking us about it. But that's sort of where we are right now.
Yeah, I agree with Phil. And I think a lot of our peers will echo that the buzzword has been contact tracing. Everybody and their brother thinks that it's so easy for them to do this work. And that has become a challenge of its own, to try to just manage that expectation that it is not as easy what people think that it is supposed to be. The issue has become, it's a control strategy that we're applying in an environment where control has failed. So in the beginning, it made sense when you have limited number of cases, but when you have huge floodgates open, excuse me, that is hard to do contact tracing. So we're trying similar stuff, just a technology solution and raising staffing.
Yeah, I've had a couple of your health official colleagues email me and say, can you try and get this message out? It's not just contact tracing. This is not going to get us out of this. There's so many other pieces of the puzzle. So, I think that's an important message that we can all continue to push out. So there are a couple questions about some data and sort of technical questions. So I'm going to move over to those. Phil, I don't know if you have thoughts about the error rate in current COVID-19 tests. Somebody had a question about that and what you all are seeing in your data, if it's been an issue or not.
Yeah, actually that's been, trying to get, simultaneously getting all the testing resources, although at the federal level, they say, oh, we got all the tests you need. It is not that way on the ground level. We were getting federal tests that, to support some of our drive-through testings, even up to 2,000 a day. And then the turnaround time was 8 to 10 days, which makes them almost worthless. So we actually turned down those free federal tests and said, look, we've been asking for just the resources, the money that they're spending on those for us to do it locally. Give us money for the reagents or let us hire a local testing lab. or, because we could turn them around and be much more nimble with that. So we're still working on that. We're using some of our CARES money along with the city of Dallas, city and county combined, to support testing. Then, as we're standing up these testing sites, getting the staff and manpower to set them up, and then finding the labs that, and the major labs, Quest and LabCorp are the ones that feds are using. The turnaround on those is an issue. Then you're trying to look at, these labs and these people who are just getting into the lab business or whatever. So, making sure the FDA and what status of, in terms of their EUA there are, and which tests they're using. I mean, we're not, the Abbott ID Now tests, the 15-minute tests we've, declined and are not because of the problems with false negatives. We are looking at some of the tests that are being done by some of the contractors, looking at some differences in the positivity rate. Then one of the things that may have been coming up, whether it's the test or it may not be the test, some of it in the Texas heat, if they're not kept cool, that may be having some impact on some of our test results. Where it's an ongoing issue, and then again, these labs are getting nationally overwhelmed, and the turnaround time. So it's either the turnaround time or the quality of the tests, or all of these issues have been things that we're juggling. And right before this call, I'm talking to another lab to see about is this another place that we could tap into to try to use it. Ideally, we would love to get reagents and have Parkland and UT Southwestern Med School, do our lab testing, but that's not happening. Just one of the many issues we're dealing with tests, in addition to the quality in which tests. And now we're having to deal with, the state has just said, now we need to start reporting probable cases in addition to confirmed, which again, a whole new thing. So.
Yeah, so our experience has been similar. Both Phil and I have public health labs in our departments, and they've just struggled from the very beginning, access to reagents and testing capability, because we were sort of the first ones, right? I mean, there was not a lot of commercial capacity, and public health labs were the ones that were able to bring the testing to local counties and cities, but we just did not have enough capacity. I mean, my lab was stuck for almost the first couple of months with like 40 tests a day capacity. That's nothing. And as things improved with the private commercial testing capacity, it also did with our labs. We got some more equipment, we got some more supplies. We actually, added another, like a commercial assay instead of just a CDC assay, so we could, do a few hundred a day. But that's a drop in the bucket. I mean, the need is for thousands a day. So we're contracting with these private commercial labs. Federal government, for whatever reason, decided that, name recognition means something, so they put locations in Dallas and not in Tarrant. I mean, we're right next door, so we caught a lot of flack for that, and we're like, it wasn't our decision. I know Phil tried to help place a location right close to a city that we share. Half of the cities in Dallas and half of the cities in Tarrant, but it wasn't enough. I mean, we caught a lot of flack in the media and with the public that you guys are not doing this testing. So we got some help from our state emergency management to put some locations here, and then promptly ran into issues with delays. What Phil is describing on the federal testing side, we experienced on the state testing side. For a while there, they had Texas National Guard and some state labs backing up the testing, and that was going okay. But as their capacity started to sort of get overrun, they had to switch to national labs, like different commercial vendors, and the delays started to occur. I mean, we're waiting 6, 7, 8 days for results to come back. So out of our 26,000 total, whether it's through a doctor's office, through public health labs, through wherever, average time frame from, testing to results is about 6 days. From being sick to getting a result is about 8 days. And if you think about it, if it takes 8 days for public health to even find out that you're ill, and then you got like, 4,000 or 5,000 cases a week coming in, you got to get that all entered, get it assigned to an investigator, get an investigation going. By the time you actually find out about contacts, it's like there's not a whole lot of time left to have a meaningful impact. So it starts with the delays and getting results back, and that has to be certainly resolved. And then comes the piece about what you asked, Christy, about accuracy. Generally, we're finding that it's how the samples are collected has a bigger impact. From a lab standpoint, I mean, most of these, if you're running a PCR, it's a well-known technology. They're doing okay. But it's the sample collection piece. If you're not doing it correctly on the site, depending on if it's medical personnel collecting it or if they just got a team of folks doing it, that has an impact on accuracy. And then the other piece is there's a lot of these pop-up private locations that are doing antibody testing and a variety of other rapid testing, and that kind of, adds to the things that get a little confused and mixed up. So we're going to try to clean that up with this use of probable case definition. The state is finally on board that, Texas needs to be using this. So we're going to, push some of that data out hopefully by this weekend. But as far as large number of tests are concerned, the majority were PCR here in the Dallas-Fort Worth area. And, that fairly accurate. It just depends on sample collection. I think if there's any issues, that's what it was.
Okay, so you guys mentioned the change in reporting probables. There's a question here about reporting of deaths via death certificates, and I was reading this in the paper also. So now that I believe the state is changing the way it's reported that COVID would be on the death certificate. Is that, which direction is that going to change your data? Is it going to be clearer? Is it going to be more or less confusing? What do you guys think about that?
The state is saying that they'll be more timely, but we're actually getting feeds now directly from the city and the county clerk's office of the mortality. And I think our EPIs have been getting the mortality, the deaths before vital records. So I think that we've been more timely than waiting for the death certificate info. So I don't know why they were saying that was something with that. I don't know, Vinny, did you have I don't know what your thoughts were on that.
Yeah, I mean, our folks are equally concerned that there might be actually delays in reporting, and there might be like data discrepancies between what we say has happened in our county and what the state actually reports out for that day. And if you think about it, we're relying on, local clinicians, hospital, nursing homes, whoever, reporting to us that there's been a death, and we wait for a death discharge summary to look for that information, and then, okay, well, we'll count that as a death. And some of that has medical examiner data in there as well. But now if you rely completely on vital records, there's at least a 10-day reporting lag. I mean, most of these places have at least 10 days to report to the vital record system. And then, by the time it gets to the state, it might have at least that much of a delay. And then is everything, going to be accurately reported? I mean, we just have to wait and see what the impact of that is. We're just a little concerned about the discrepancy numbers because it confuses the public, right? I mean, Tarrant County saying something, the state is showing something else. So we're just trying to, it's brand new, so we're trying to see what the impact of that is, how do we reconcile all of that, and go from there. But maybe their system is better. One of the benefits that they mentioned was that they'll be able to report by date of death, which we are already doing it since the beginning. So I don't know that that's any better than what we've got. We'll just have to wait and see what changes they're able to bring.
Okay. So, we talked a little bit about schools at the beginning. There's a question here about community spread and hospitalization rates in childcare facilities, youth sports, and summer camps. Over the past couple months, what have you guys seen? What's sort of your takeaway from, I think what people are realizing is a fairly small sample because the world shut down. So a whole lot of kids weren't exposed. So what are you all seeing, and how are you considering that, as you talk about schools opening and things like that?
I mean, I think that's a really good point you make, that we've sort of, we've been reporting now recently, like the number, I think we've had like 64 or something daycares with at least one staff or child in it. We've had, I think, a total of over, 4,000 kids under 18 in the month of July. It's been a couple thousand or But it has been in this setting where school's been shut down. So, you know, and we're looking at all the other information about there regarding, you know, how important is the transmission in schools. But certainly, I mean, we have had significant numbers of kids, and it's picked up in the last month and a half. And, you know, probably with more activity that's been going on with some of these camps and things like that is what has opened up. And the camps are now allowed, I think under the governor's orders, allowed to be open. So we have seen upticks in numbers. We had talked with some of our hospitals. One of the hospitals certainly has seen significant numbers of kids and hospitalizations. A couple of the others hadn't. But I do think that part of that interpretation of what's gone on, certainly local, you know, in the States, has to be in the context of, you know, most places had shut down schools for them since March.
Yeah, I agree. I mean, March 13th, around that time is when Tarrant County shut down their schools. And I think you guys went like a day ahead of us, but it was pretty much about the same time frame. And, you know, the data, you know, at least in Tarrant County shows 5% of the cases are in under 15 age group. So that's been sort of used against us, that you're not, you know, following your own science and you're shutting down schools because of some, you know, political motives or whatever it is. I mean, that's just, you know, the lingo that's been used. And what we're saying is that that data is so skewed. I mean, we had stay-at-home orders. We had schools that have been closed since March. Then summer break hit. So there's really not a lot of data to rely on for that age group. What we do see, that daycares were open, but because the stay-at-home orders were in effect, daycares had to shut down because there was no business. So about 55% of the daycares were open. You know, everybody else kind of like, yeah, well, nobody's bringing their kids, so we're just going to take a break. And as the economy reopened around Memorial Day, parents went back to work, and we started to see a huge surge in cases. So they would drop off their kids at daycare, and now we were seeing daycare outbreaks. They haven't been, you know, crazy outrageous, but it's been a lot of outbreaks in different daycares. And it's tied to the economy reopening, young parents going back to work, getting sick, bringing it home to the child, and then daycare having an outbreak. So there is transmission there. Logically, if you put thousands of kids in school together, you're going to have problems. But the data is not there to support it right now because, again, we go back to March was when we closed the schools and everybody stayed home. So it's kind of worked against us a little bit, not having that information, but, you know, we fully expect it. I mean, we see it every year in the flu season. You know, school opens, flu picks up, they take a break, flu goes away for a little bit, they come back, flu picks up again. So what's so different about another, you know, respiratory infectious illness? Not much.
Yeah, I mean, our Dallas data has been like 10% or under 18, and then we've had 1,800 kids diagnosed, confirmed since just July 1st, and we've had 38 hospitalized, 4 admitted to the ICU. You know, so there's some numbers and some significant illness in some of these kids. And we had a death of a 5-year-old just last week.
So, you know, Vinny, you mentioned masking and how you guys have seen an impact, and there's a question about, you know, public debate about how effective masks actually are if they're not N95s. Do we know enough at this point to say absolutely let's all use cloth if we can't get N95s? What do you guys think?
Yeah, so, I mean, at least I've been saying since the beginning, and I'm sure a lot of our medical peers will, you know, support that N95 is best left for medical professionals, right? Healthcare professionals. And the reason is you get a training on how to use that mask. It's called fit testing. You're supposed to learn how to get a good, you know, fit around your face every time consistently for it to work. What works against people and their understanding is that they see N95s available at Home Depot, Walmart, Kroger's, everywhere for woodworking in their garage. So they're like, oh, this is so easy. I can put that on and it's going to protect me. Well, in that setting, you're not dealing with a microorganism. You're just dealing with particles. That's fine. But to protect against in a healthcare environment, you need a good fit. So I personally don't recommend N95s for the general public. What we do support is general public using just a cloth-based face covering or just a regular surgical mask, those disposable ones. And the logic behind it's not necessarily just to protect you, it's to protect others. I could be the one, walking around asymptomatically shedding the virus, not even know it, or might have a tickle in my throat thinking it's allergy season, and I could be making others ill. If I put on a mask, that's what it was designed for. It was a surgical mask so that when the surgeon's operating, they don't infect the body cavity that they're operating on. So it protects you from spreading the virus to others. Is it 100% effective? No. Studies vary, but average is about 70% is going to stop the particles from coming out. And then if you couple that with everybody wearing it or others wearing it around you, they get a little bit of protection by wearing a mask, 5–10%. And then if you maintain a social distance of 6 feet, you're getting pretty close to getting 100% protection by wearing that mask. And that's how it works. And that's why it's been so hard. In the beginning, there was debate, don't use it. One, things were in short supply. Two, just a general understanding that people are not going to use it correctly. I see so many people that are wearing it right here on their mouth, but not on their nose, or right on their chin. Like, what's the point of that? So those are the type of things that we were like, okay, don't even try it because we're not going to do it right. And then we need everybody to do it. And it's hard for anybody to say that everybody's going to do something, right? And as soon as it, was recommended, yeah, everybody should do it, we got people coming out of the woodworks. You're taking away my personal liberties, and we're not going to do this. And so it minimizes the impact of that effort. It's kind of like vaccines, right? You got to have herd immunity. You got to have a minimum number of people, majority of people getting vaccinated so we can protect others. Same thing with these masks. It's a public health effort. Everybody needs to do it so that it can have an impact, as close to 100% as we can get. And that's where the issue is. If it's a 50-50, you're not going to see a benefit of it. But if majority of the people in your community start doing it, you'd see a downturn. We're seeing that here in Tarrant for sure.
Okay, so we have about 5 or 10 minutes left, so I'm gonna ask a couple more questions, and if folks have any additional questions, those of you listening, please do type them into the chat. So we've seen and heard a lot about the mental health of frontline workers, and the media that's focused a lot on doctors and nurses in hospitals. Obviously, you and your staff have been working 24/7 for months. What toll is that taking on your teams, and what types of things are you all doing to try to minimize that impact, knowing that this is a marathon, not a sprint?
Well, I guess I'll go first. So certainly everybody's tired. I mean, public health staff, people don't even realize, I don't think even healthcare folks were that much in tune and working on this. We started in January. Like, as soon as the news broke out that China's got a problem, our folks went into a tizzy trying to prepare and be on calls and learn about the disease and prepare plans and all those type of things. And then, of course, when it became a reality for all of us, things just went crazy. I mean, I can tell you a lot of us have pulled, countless hours. I mean, a typical day might start, and never end. That's kind of just how it goes. Late into the night, conference calls and just working for the next day, less than 4 hours of sleep for a lot of our people. And that's been going on, since the beginning. So that's reality. We're tired. They're irritated because when they make all of this effort and then there's a lot of pushback either from the public or the media or the politics, they get irritated because they know that they've put in a lot of effort and checked out all the facts, checked on the science, and given good advice, and then it's just kind of being shredded based on opinion. And that hurts, because when you work that hard for something, it becomes personal. Our folks are troopers. They're going to pull through it. But I got to admit, this is overwhelming and tiring for all of us. I mean, it has been, and I'm sure my folks are, burning out, and we're trying to infuse new staff, but they haven't been able to get a break, and it's just been nonstop.
Yeah, I mean, obviously same situation, and I mean, we have staff. I know the EPI staff have been working 7 days a week till really, midnight, many nights, dealing with these reports through the weekends. No breaks. I mean, we try to, say, and our judge, really reinforces everyone needs to be doing some self-care because this is a long-term deal. It's not a short-term, and it's sort of, we all have to sharpen the saw a little bit and take that break just so we can get through this. But it's a tough time, and because there's a lot of demands on everyone. I know our lab people getting these labs turned around in our own lab, all of that. I mean, and so we're, trying to do what we can. I know that, but it's a difficult situation. I would say, yeah, I mean, one of the questions that you had given us out earlier, how like Vinny and I communicate or whatever, and that is probably one of the biggest things, just that support to commiserate with whatever's going on immediately, because yeah, it does get very tiresome to have to deal with this. But yeah, I mean, we try to get. I know, I mean, no matter some staff, you tell them you need to break. We need to have some backup staff and things like that, and have that built into our staffing, and it's just hard for people to do that. And sometimes it's self-inflicted, but we just have to keep pushing for that.
Yeah. All right. So last question. What do you wish you knew sort of at the beginning of all this that would have been most helpful to you now as you continue to respond, 5-6 months later?
From my standpoint, I wish that we knew that what is a way out of when somebody swoops in and writes a whole different plan, and then they don't follow their own plan. It's like, what do you do at that point? I mean, we can only educate. Our power has been eviscerated. I mean, we don't, other than making a recommendation, we can't do anything at this point. And it becomes very, very challenging. How do you navigate that environment? I mean, we're feeling the pain. Our community obviously is complaining. There's, in Tarrant County, there's 36 or 26,000 cases. That's a lot of hurt in our community. And it's hard to balance. I mean, I understand where the politicians are. They have to balance the economy and the other side of businesses just going bankrupt and restaurants closing. I mean, all kinds of things have gone bad. I wish there was a national concerted effort. I know it's a big country, but we needed a very strong national strategy, and I wish we had that. It's never too late. We still need it, and I'm sure states will follow when there's a strong national strategy. We just don't have a good one right now, and it's been very disjointed.
I'd say, one thing maybe, hadn't really thought this through, but, if we had in place some more resources and things for communication and messaging, I've done a lot in the history with tobacco, and, we had media agencies on board and, looking at getting these messages out. I mean, even with Zika, there was a lot more messaging resources and tools to get things out. I think that that's something I wish we had more of that in place to support, like getting out the messages and use more of the media to reinforce the masking, this physical distancing, washing of hands, other things that, I don't think we've had it in place as much as we have with some other issues we've had to respond to, perhaps.
Yeah, I think those are both valid points, and I think things that everybody's trying to drive home and fix in retrospect all those pieces of the puzzle. So thank you both so much. This has been a great discussion. Appreciate you giving up an hour of your time. And thanks everybody who joined us. This webinar and the first 4, I guess, are on our website at the address you can see at the bottom, bigcitieshealth.org/events. We have a couple weeks off here with scheduling, but we're going to have 2 more sessions back to back. Wednesday, October 26th, that's where my brain is. August 26th, we'll hear from health officials in Columbus and Phoenix, Maricopa County. The week after, Chicago and Minneapolis, and then we're hoping to schedule a couple more for later in September. Gabby, the next slide has our contact info. You know, if we can be of assistance to you all, let us know. Have a great afternoon. Thanks again, Phil and Vinny. Really appreciate it. Hang in there.
Thanks.
Thank you, folks. Bye.
Bye-bye.